Good morning. Welcome to American Academy of Optometry Foundation's clinical podcast. My name is Drew Rixon. I'm the guest host as well as the topical editor for the glaucoma and retina portion of these podcasts. Today I'm joined with Dr. Pathik Amin, and he's going to be our topical expert. The first journal we're going to be covering, or article we're going to be covering, is going to be the comparative analysis of 24-2C, 24-2, and 10-2 visual field testing for detecting mild stage glaucoma with central visual field defects. Dr. Amin, why don't you first just tell us about where you practice, and then we'll get into kind of just discussing the article here.
Sure. Thanks, Drew, for inviting me. I'm excited to be here and discuss a couple glaucoma articles. So I practice at the University of Illinois, Chicago, Department of Ophthalmology. I'm attending in the glaucoma service. And prior to this, I was at the University of Chicago. So I started here about 6 months ago.
Perfect. All right, well, let's talk about this case. So of the articles we kind of looked at to try to decide what we would use and what had value, what was it about this article that stood out that you thought would have value?
Yeah, sure, Drew. So, it's now well established, thanks to some tremendous work over the years from Donald Hood's group at Columbia, that there can be isolated central visual field loss that's common in early glaucoma, particularly when we're using 10-2 visual fields early on. And the question almost always becomes when this topic comes up, but how do we test for this? We only have a finite number of opportunities to perform visual field testing, which has its own challenges from the patient side in terms of a learning curve and reliability. So do we sacrifice an opportunity to perform 24-2 for 10-2, which presents as an opportunity cost? We lose a data point for guided progression analysis. Do we perform 10-2s on all patients or just some patients? There are perhaps some structural biomarkers on OCT scans that may clue us into which patients might have early central loss. And certainly the introduction of the novel 24-2C protocol incorporated more central points, 10 more central points from the 10-2 into the traditional 24-2 test pattern in hopes of finding a middle ground. It's still unclear how the 24-2C fits into our practice patterns. So this article is definitely intriguing because it helps further elucidate the role of 24-2C into clinical practice.
Excellent. And it really is, it's an ongoing debate. So I think any additional information just kind of helps clarify. So how did they go about trying to compare 24-2C and 24-2 and 10-2? Seems like a lot to compare.
Yeah, certainly. The study looked to identify which one of these testing programs detected the presence of central loss in patients with glaucoma, mild glaucoma, the best. This was a multi-center retrospective testing evaluation. It consisted of 93 eyes with mild glaucoma plus central visual field loss and 69 eyes with mild glaucoma without central visual field loss. And the study authors compared the detection power of 3 different groupings of test points, which for our listeners, this might be easier for you to visualize if you look at the figures supplied in the article, which will be linked below. The first group was strictly using the 4 points, center 4 points on the 24-2 test pattern that coincide with the central 10 degrees of the visual field. And this was termed center 4. The second group utilized also the 24-2, but used the 12 points that correlate with locations on the 10-2 testing grid. And the last group utilized 22 points from the 24-2C test that correlate with locations on the 10-2 testing grid. So what were the results? Well, the study authors reported on testing time, and as you'd expect, the 24-2C was faster by about 50%. The 24-2C to standard and the 10-2C to standard on average took between 5 to 6 minutes, which is kind of what's reported in literature, whereas the 24-2C was significantly faster with an average test time of about 2 minutes and 45 seconds. The authors looked at the accuracy of each method, center 4, the 12 points from the 24-2, and then the 22 points from the 24-2C, and analyzed them in terms of their ability to detect central visual field defects. And they found that the 24-2C performed the best. Interesting, the study also found that central visual field defects were more common in the upper visual field than in the lower visual field. And this is consistent with previous reports that, and likely coincides with the macular vulnerability zone, a term coined by Donald Hoodin's group, which finds that most of the inferior region of the macula projects to this MVZ or this macular vulnerability zone, which is located largely in the inferior quadrant of the disc, a region that's particularly susceptible to glaucomatous damage.
Yeah, it's definitely been a very popularized, finding overall. Did you have any concerns about them using standard versus fast? I mean, obviously that would really stratify the difference in time. Or did you feel like that was just pretty much because the standard, even though fast is now acceptable, the standard's kind of been what's been used in the past? What do you think about that?
Yeah, I think that's a good point. Standard is, like, as you mentioned, is kind of the gold standard, or kind of the standard practice. The faster, has its own challenges in terms of reliability. They are able to shorten the test time by introducing or reducing the number of steps, right? So this has led to more false positives. So certainly maybe the 24-2 CETA standard is a little bit more thorough. But there is some literature out there that shows that in early glaucoma, really the testing protocol doesn't really play a big factor into sensitivity.
Right, great stuff. So overall, what's your take home to any of the listeners in clinic? How does this change the paradigm? Does it change anything for you?
Yes, I think the clinical take-home message here is, if the question was, where does 24-2C fit in? I think given the accuracy of detecting central defects and the testing time, it may be more useful when testing patients with mild glaucoma that you are suspecting central visual field defects or just want to screen for early central loss. You have to keep in mind, and what I mentioned earlier was that CETA faster is associated with a higher rate of false positives, and so it may not be great for poor test takers. So that is kind of the downside. A previous study also found that if you're transitioning existing glaucoma patients from CETA standard to CETA faster, this is associated with actually an improved visual field performance in patients that have moderate to advanced glaucoma, but there's no difference in visual field performance in mild glaucoma. So while the 24-2C may be beneficial in screening those with early glaucoma for central visual field loss, it may actually obscure detection of worsening disease in those with more severe stages of glaucoma.
Right. Fantastic summary of this article. And I really do appreciate you being on today. And I'm absolutely sure that our listeners got a lot of value out of the information you provide. So thank you, Dr. Amin, and thank you for everybody listening and tuning in today.
Thanks for having me.